beta thalassemia. So what is it? It is a autosomal recessive inheritance. Here what happens? Two genes in chromosome number 11. Okay, what happens here? Point mutation. What is that type of mutation? Mutation. What is it? That is splicing. Mutation occurs. Okay, so what types we have? We have multiple types. The beta is normal. If one beta normal, one abnormal, then I have the mild. It is asymptomatic. I can have mild anemia. If both of them are there, or it is like this, then both of them, it is intermediate. Here I have anemia, I have jaundice, my spleen and liver will be get enlarged, everything will be there. So I need what? I need blood transfusion all life. And next is beta naught. It is beta thalassemia major. It is also known as Cooley's anemia. Or Mediterranean anemia. It is the most severe. This is a PYQ, most severe. All life blood transfusion is necessary. Okay, in both of this, blood have to be given in each and every month. Okay, now what is the pathophysiology? In this pathophysiology, so pathophysiology is that no beta globin gene synthesized. Okay, so alpha gene accumulates. That's why RBC unstable, not RBC actually, unstable cells that get destroyed, early destruction leading to ineffective erythropoiesis. This is a PYQ. Because of this ineffective erythropoiesis, there will be severe cell destroyed. Because of this, severe anemia will be present. So transfusion is needed. But because of this transfusion, iron overload will happen. And because of this, congestive cardiac failure can happen, and that will death of these children, of the child, will happen due to congestive cardiac failure. Okay, in normal cells, one a beta and alpha produced at 1:1 ratio, but here it is not doing that. And also due to ineffective erythropoiesis, another thing will happen, that is compensatory extramedullary hematopoiesis. That means in different places the erythropoiesis will occur. Compensatory production, where in the skull, in liver, causing liver hepatosplenomegaly, spleen and skull. Because of this, in the skull, what we have chipmunk face, that is also called thalassemia face. Okay, we have hair on and appearance, that is truant appearance. So if this is my skull, skull, I have hair and appearance on the skull. Okay, and skull will expansion. Okay, this maxillary prominence on the cheeks will be prominent, maxilla prominent. Maxilla means cheek, gall. Frontal bossing will be seen. So just make another picture. So if it is this, so what I have from frontal bossing, the depressed nasal bridge will be there. Nasal bridge, depressed, prominent nasal, prominent maxilla, and dental malocclusion means daant will be like this, not a straight. Dental malocclusion. Now let's talk about the main parts, that is investigation. So I will do peripheral smear, and in that what I will find, microcytic, hypochromic RBC, nucleated RBC, because RBC production is not properly happening. Next investigation will be hemoglobin erythropoiesis, electrophoresis. The last one, gold standard, that is HPLC. Gold standard, that is high performance liquid chromatography. What is the management then? So the management is, first one, as we see, blood will be given, and the second one is HSCT, that is best curative, that is stem cell transplant. So what stem cell? Hematopoietic stem cell transplant. Now, regarding this blood transfusion, we have multiple things to say. The first one is, because of what type of blood is given. The blood has two things. There is no less leukocyte, so allergy, for allergy chances decreases, and hemoglobin level target is 8 to 10 gram per deciliter for growth, promoting growth. Okay. Now, because of this, iron overload will happen. And due to iron overload, what happens, we know. So regarding iron overload, some important PYQs. The first one is, it affects whom? Obviously, iron is liver, spleen, and heart. And it leads to congestive cardiac failure that leads to death in these children. Okay. Also, there is a risk of infection by whom? Yersinia enterocolitis. PIQ, that's why I'm writing. Due to decreases the bacteriostatic properties of lactoferrin. Due to decreased bacteriostatic property of lactoferrin. So how we know that it is iron overload is happening? So it is also a PYQ. Serum ferritin is more than 1000 picogram per liter. And also we can do MRI as well. So what is given for all of this? The treatment is deferoxyrox. That is most common and given orally, and it is a PYQ. Otherwise it is I can give IV or SC, deferoxamine. Deferiprone also can be given. Finished.